from the American Academy of Pediatrics.
Pediatricians have always seen the value of preventing harm.
And when that harm might be coming from a child's caregiver, it's our job to help.
We're not asking pediatricians to gain new skills. We're asking them to recognize this is a problem like a bad blood count. This is a problem like having a funny rash.
Plus, treating children with ADHD in the medical home benefits both the child and the pediatrician.
There's nothing more satisfying than taking care of a kid with ADHD through their early childhood years, teenage years, and into adulthood, and see them thrive and become really outstanding adults.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Malinky. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a conversation about preventing the maltreatment of children in our care.
Last week, we heard some practical ways to assess and improve relational health.
And I think it's a conversation we'll continue to have as we integrate the concept into practice and medical training.
And that's why I'm excited to talk about a clinical report from the Council on Child Abuse and Neglect, the pediatrician's role in preventing child maltreatment.
Here to tell us about it is Dr. John Sterling. He's a retired general pediatrician and the former director of the Center for Child Protection at Santa Clara Valley Medical Center in San Jose, California. He also was the first director of the Child Abuse Program at Stanford Children's Hospital. Dr. Sterling, welcome to the show.
Thanks, David. It's great to be here. I couldn't ask for a better intro.
Let's start with the basis of the report. How does relational health play a role in preventing child maltreatment?
Relational health is a term that describes the health of relationships. Children are dependent. We grow up in families, and when born onto the earth, the children really are, I hate to say this, they're not very smart. They haven't had a lot of experience. We learn about the world, we learn about the way it functions, we learn about our role in the world through the relationships we maintain with the people on whom we depend as children. The parent's role from the very beginning is as an educator. Model good behavior, show the children how to create their own relationships from which they can learn more about the world. So health depends on good relationships. Good relationships, in turn, if they're safe, stable, and nurturing relationships, can teach a child to be resilient. They can teach the child coping mechanisms that will help them survive an adverse event. An example of resilience would be a rubber ball. It bounces, it deforms, and then bounces back to its shape again and carries on, as opposed to, say, an egg, probably the least resilient thing you could drop on the floor. So what we try to do when we talk about relational health, we're stressing that good relationships are what help a child to resist damage and injury from bad things that can happen to them. The concept of relational health, and especially as it relates to prevention of child maltreatment, also extends to the families, the adults. When we talk about the incidence of child abuse, it's a very prevalent thing. We're talking here about maltreatment, abuse, neglect, at the hands of someone on whom the child should depend. In other words, from parents and caregivers, teachers, coaches, clergy, etc. If a stranger comes up and assaults a child, that's just assault. Child maltreatment has several forms that include not only physical abuse, which is the first thing that comes to most people's mind, but also sexual abuse and neglect. Interestingly, of the things that can happen, the bad things that can happen to a child under the ages of child maltreatment, neglect is far more common and far more dangerous. More children die of neglect than die of physical assault.
And can you give us a sense of the scope of the problem? How many children are victims of maltreatment?
It's a difficult statistic to obtain accurately, Joanna, because a lot of child maltreatment doesn't come to the attention of people outside of the family. Children can be reluctant to disclose or unable to disclose what happened to them. The abusers are either stricken by guilt or or for whatever reason are reluctant to tell anybody that this happened. It's seldom witnessed. And I hate to say this, but even the professionals who are responsible for detecting and intervening oftentimes are awkward discussing it, awkward to have a hard time believing that this could have happened. So our reporting is probably underestimating the number of kids who are maltreated. As far as the statistics we do have, about 500,000 children every year. That's the incidence every year. And since you're a kid for 18 years, that builds up to a pretty hefty prevalence. There are a great many adults who can recall being abused or maltreated as children.
John, I think we know the maltreatment of children is nothing new, but when did it become something we take care of in pediatrics?
Actually, David, child abuse is a fairly recent medical concern as such. Although people have always abused their children, it was first described well in our modern medical literature only in the 60s. And our awareness has grown. And of course, it came in good time. Once people realized this was happening, it was obvious we had to do something about it. First step took the form of detecting children who were being abused and stopping that. That's obviously the most important part of preventing. We've done pretty well with that. I think we have courses now. We have physicians who are specially trained. We have public awareness has increased dramatically that caregivers and parents can abuse their children, everywhere from the neighbors all the way up to the Olympic teams, that we've been reading about recently, have been victims of child abuse. So we've got that part underway. And you can see the incidence of child abuse has actually fallen dramatically in the last 30 years. Statistics are very impressive. But that's apprehension. That's one part. Pediatricians see children while they're being abused, but we also see them before they're abused. And we also see them after they've been abused. Children who have been abused once are at much higher risk for being abused again and having dire consequences later in their lives. There's a whole body of literature that's evolving now showing that long-term consequences of childhood abuse. And if a child is not recognized as a victim, and if those consequences are not addressed early, we see a broad spectrum of health consequences from early childhood adversity.
I appreciated some of the history you gave of child abuse literature and recognition. When we talk about the subspecialty of child abuse pediatricians, does it follow the same timeline? What role do they play in all of this?
That's a good question, Joanna. The specialty of child abuse pediatrics has only been formally recognized since about 2009. And there are now a body of child abuse pediatricians, and most major cities, most major medical centers have someone on staff or affiliated. The specialty grew out of our need to develop a better insight as to what happened with children and to have actual science to guide us rather than just taking a first impression. If you look at the body of literature that's been produced since the recognition of battered child syndrome back in the 60s, it has been exponential. There's a great deal of research now about what does or does not represent an accidental versus an abusive injury, what characteristics are seen, how investigations should be conducted, what imaging modalities work best, and a great deal of science as far as how an injury actually comes to occur relevant to inflicted injury versus accidental. So child abuse pediatricians serve as a sort of a conduit to that body of literature. To be a child abuse pediatrician now, you have to undergo a 3-year fellowship in child abuse, as with most other specialties. So I think we're working hard to raise the level of scientific awareness. But curiously, and I find this very interesting, studies have been done to see what is the effect of having a child abuse pediatrician consult on injuries. And the answer is there are a great many more cases that are disproved as abuse. Pediatricians are actually more likely to find that a referral did not result from an intentional injury.
So, looking at the clinical report, there's some real implications for how we approach our interactions with children and with families in the exam room that can help prevent maltreatment in the future for these kids. Can you talk a little bit about what we need to be thinking about when we walk into a room?
I sure can, David. What the paper recommends is when we walk into the room, as you'd asked, pediatricians should make a special effort to assess and remain aware of the relational health of the child and the family. In other words, what are the relationships like in the environment in which this child is developing? Now, we do that to some extent all the time. We take histories, we take social histories. Paper suggests that this is more important than a lot of docs will give it credit for. That taking that relational history is giving us some warning as to whether there are risk factors, giving us some appraisal as to whether the child is in a strong place or a weak place, a vulnerable place. So the first thing, the most important takeaway from the paper, is that we should be paying attention to the relationships in which the child thrives, and we should be doing what we can to encourage those. We should all think of child maltreatment, I think, as a balance between risk factors and resilience. There are always going to be crises. Families are going to be in crisis. Children are sometimes more needy. The question is, how do those challenges, how are they met by strengths? So we can learn by paying attention to families, we can see where they are challenged. Is there enough food? Is there violence in the community? Is there housing for the family? That's on a community level. On a family level, we can assess in their interactions the awareness this parent has for the normal course of child development. How is he or she going to deal with the normal stresses of things like toilet training, like sleep problems? How is the child developing the things that will protect him or her when it's needed? Can that child talk to adults? Does that child have language skills? Is that child afraid, say, of a harsh or punitive sort of a parental environment? Is she afraid she's going to be punished for telling somebody what happened? These are all things that we can assess when we take our histories and gain a better knowledge or better understanding of what kind of relationships this child is part of. We talk about prevention. If we were preventing malaria, we would use the same techniques. We try to decrease the number of people that have it, which we've already done. We try to make people stronger. If we could immunize them, great. If we could give them mosquito nets, maybe that would help. And we're doing exactly the same thing here that we did for polio and smallpox and God knows what else. We don't have an immunization, but we do know what works. And what works is making the children and families stronger, giving them the tools they need. As a child abuse pediatrician for a bunch of years, I very seldom met an abusive parent who set out to abuse the kid. You ask anybody who's in a child abuse situation, they will almost always say, I did it for her own good. I wanted her to be a strong teenager. I didn't want this guy to get in trouble when he got older because he didn't know the rules. So I beat the hell out of him to make sure they knew what the rules were. Or I would never do this to my child except that I hadn't slept for a week. Or I didn't want my husband to beat him, so I beat him. And it's just stuff, you hear stuff like that, your heart goes out, even to the people that abuse their kids, because they don't do it on purpose. That's a big difference from, let's go get those bad guys who are abusing our kids. I was working to edit something that the AAP had published the other day, and it was more or less how a parent can stop people from abusing their children. Well, how can a parent stop from abusing their own kids and help protect your children when you think other people in your family are doing it? Is sort of the big issue.
This feels like a lot for pediatricians to take on alone. What community resources can we tap into to partner with us on this mission?
Well, we've been talking about diagnosis here, talking about paying attention to those relationships. The next step is to see what we can do to help the ones that we see are weak. And sometimes that involves simple enough things. I can talk to a family about effective discipline as opposed to punitive discipline. We know that punishment doesn't work in many cases. I can teach that spanking, for instance, is probably not the wisest way to teach your child what he or she needs to know to get through the day. Some of it's just anticipatory guidance like that. 2 months old, that kid's going to be up every night. I walk in and I say, is the child keeping you up all night? And when they say, Yeah. They're reluctant to admit that, but they say, yeah. I say, perfect. She's doing exactly what she should do. And this is why. You talk about the developing brain and how they need to adjust and how we deal with it. So simple anticipatory guidance is something all physicians can do. We can be alert to the community resources, and, all pediatricians take a social history. All pediatricians should know how to make a referral when something's needed. If I get a wonky blood count, I know who the hematologist is. That person's right there in my list. I can call them right away. If I see somebody whose relationships are weak, I see a first-time mom who's homeless. If I have my address book ready, I can make a referral to somebody who can help with that. If I see somebody who is really if they come to me, for instance, because their child is oppositional, I can make referrals for parenting resources, classes that have been shown to work. A parent of a newborn might benefit very much from a home visiting program who can assess how well they live. What's their environment physically like? How do the parents interact with the children from day to day? Is there enough food? Is there heat? So home visiting programs, parenting programs, drug, alcohol, and mental health resources, we all have those on speed dial, if you will. And those are obviously strong impediments to having healthy relationships for the child at home. So there are lots of things we can do, and I will stress again, because I can't stress it too often. We're not asking pediatricians to gain new skills. We're asking them to recognize this is a problem like a bad blood count. This is a problem like having a funny rash. If you see a child whose relationships at home are weak, a child who is not developing resilience, that is cause for alertness, further investigation, and a referral, just as we would if a kid had a funny rash or a peculiar injury. So again, not new skills.
So, Dr. Sterling, this report is so comprehensive that I really think every practicing pediatrician needs to open it up and read it themselves. And understanding that you can't summarize it all, is there one takeaway that you want to make sure everybody goes away with before they read it?
I think the most important takeaway from the paper is that preventing long-term morbidity from child maltreatment depends on assessing, monitoring, and assisting families to develop healthy, stable, strong, nurturing relationships with their children, and for the children with the teachers in the community, and with the parents, with their family and their community. So the safe, stable, nurturing relationships are something we can assess and address using the skills that we have developed as pediatricians over generations.
That was beautiful. Dr. John Sterling, thank you so much for joining us today.
It's a pleasure.
To read the clinical report, The Pediatrician's Role in Preventing Child Maltreatment, go to aap.org/podcast.
Coming up, we'll look at the value of diagnosing and treating ADHD in the medical home.
I feel like more and more we are seeing shortages of things where I practice. Betamethasone a year ago. I think people remember when formula types were low. And not having these things in our routine care is really stressful.
Well, in the NICU, you deal with a very specific patient population, so you can imagine how the pediatric population at large feels when we have shortages of commonly used medications. My wife, Christy, has been super frustrated with the ongoing shortages in ADHD medications. She feels like half her time in child mental health is now spent calling pharmacies and changing prescriptions for children whose symptoms were perfectly well controlled on a medication they just can't get any longer.
Ugh, I can't imagine how frustrating that is when it can be hard to even diagnose ADHD and then not being able to treat it.
Diagnosing can be challenging, in part because it's so time-intensive. I've done plenty of it myself, but that intake evaluation feels like it goes on forever. It's no wonder primary care pediatricians feel overwhelmed trying to manage ADHD in a busy practice.
What if we could give them some help? Let's bring in an expert, Dr. Edward Curry. He's been a pediatrician at Kaiser Permanente Fontana Medical Center for over 40 years and is the chairperson of the AAP's ADHD Clinical Practice Guidelines Subcommittee. Dr. Curry, welcome to the show.
Well, thank you. Thank you for having me on board. Appreciate it.
So, Edward, are there systems that general pediatricians can use in their offices to ensure that they make accurate diagnoses of ADHD more efficiently?
Yes, so at Kaiser Permanente, we've developed a system where we have this learning and behavioral packet that we give to the parents that both the parents and the teacher can fill out beforehand. So we can collect all the pertinent information before they even get to the office. In our system, we won't even schedule a patient unless we have all of that information to make it a worthwhile visit for the patient.
And what kind of barriers do you see that can make it harder for general pediatricians to set up systems like these?
It's more having the staff and then the time. So having someone truly dedicated to your patients with ADHD that can follow up on making sure the packets are received, follow up on scheduling the appointment, and then doing follow-ups and scheduling follow-ups for the patients after the initial evaluation is done.
And why is it important that pediatricians keep these children in their offices and build a medical home for them, as opposed to referring to a developmental behavioral pediatrician or another specialist for evaluation?
I think it's critically important for the pediatrician to follow them. They know the patient, number one. They've seen the child, they know them, and they can follow them longitudinally along the way. Me, I've been practicing for 40 years, so I've seen ADHD and how it progresses. And there's nothing more satisfying than taking care of a kid with ADHD through their early childhood years, teenage years, and into adulthood, and see them thrive and become really outstanding adults.
We mentioned the ADHD medication shortages, but how are those affecting families and the pediatricians who care for them?
Just as you said, it's a tremendous burden on them trying to find the medication, getting the prescription. I've had patients go to 5, 6, 7 different pharmacies in an attempt just to find the medication that the child needs to be on. And then even with that, they don't receive the medication they were on, say Concerta. So we have to switch to a different preparation, and that can cause different issues for the child.
And do you see any relief on the horizon?
This has been going on for about a year and a half. Recently, we've been seeing a little bit more of the medications becoming available. We have a website within our system where we can take a look and see where the medications, the different formulations of medications are available. And it looks like it's lightening up some. But still, it's parents can have a really difficult time.
I've had family and friends tell me they don't want to use medication or want to use as little as possible for kids with ADHD. How many children actually need to manage this with medication?
If they're coming into the office and we've diagnosed them with ADHD, then 70 to 80% of the kids would potentially need to be on medication.
And what are other therapies they can utilize along with medication?
A lot of things we recommend are parent training, organizational skills training, behavioral training that they could get through behavioral health are quite helpful in terms of managing the symptoms of ADHD.
And I know this can be overwhelming in general practice. Are there resources that you think general pediatricians should know about to help them with problem solving when it comes to managing children with ADHD?
I think the best tool for pediatricians to have in the office is the ADHD toolkit, which is available through the AAP publishing department. If you have that contains all the information you need for every aspect of ADHD for you to be able to take care of a child with ADHD and help the family and provide resources for them and tips on how to manage behaviors.
With you as a resource and with that toolkit, I'm hoping that pediatricians are starting to feel empowered to manage this in their clinics. Can you talk a little bit about the process of updating the toolkit?
Yes. So right now, as I stated early, I'm chair of the ADHD Clinical Practice Guidelines Subcommittee, and we're updating the guidelines from 2019. So in that vein, we also need to update the toolkit. So when you look at the toolkit as it is now, there's a survey that you can take, and we really would appreciate people to go and take the survey and provide us input on what they see and what's needed in the toolkit so we can help improve it when it comes out.
Dr. Curry, I sometimes just go to the same sessions over and over again at the NCE because I never feel like I can learn enough. And I have to confess, one of those sessions is how to diagnose and manage ADHD. And you're presenting that this year. So can you give us a preview of what I'm going to hear when I yet again go to this?
Yeah. Yeah, Rick, I'm going to be presenting how to diagnose and treat ADHD in a busy practice. And so the most important part is learning and developing a workflow for the pediatrician to be able to manage and treat these kids in their office, in a very busy office, and how they need to set up the workflow, the patient evaluation, the follow-up and assessments, and follow-up appointments for the children they see in the office.
And Ed, before we let you go, is there one takeaway about this topic you'd like pediatricians to know?
I like them to know that they can manage kids with ADHD. It's not that imposing a disorder, and you're going to see it frequently. And the impact you can make on the child for them to be able to improve in their childhood, their adolescence, and into adulthood can be tremendous and very satisfying.
And in your many years of practice, do you have any stories of successful ADHD management that you want to share?
Gosh, I've got so many of the kids that I've taken care of over the years. It's been 40 years. We started out when we only had Ritalin as the only medication, and now we have all these different preparations of ADHD medications. But to see the kids really improve as they go along, their self-esteem. A lot of these kids have low self-esteem because they can't do it. And to see them on medication or get some behavioral therapy, and then for them to be able to thrive and go on to college and then graduate from college, and then to send them pictures. I've got a whole wall of pictures of kids that I've taken care of that have graduated from college, and they'll send me their graduation pictures and even some of their college pictures is completely rewarding.
Wow. That is really inspiring. That's a good reason to get up and do this again today for all of us. Dr. Edward Curry, thank you for all this great information, and thanks for talking with us today.
I appreciate it. Thank you for having me on.
To learn more about managing ADHD in the medical home, go to aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, Joanna, one thing you and I have in common is a history of competitive swimming. And it took me forever to get back in the neighborhood pool this year for my, summer of laps. But I'm back, and I forget until I'm in there just how amazing it is to feel that water and to watch the ripples as the little, droplets hit and refract the sunlight. And I'm just really enjoying being there. And then I'm surrounded by other people from the neighborhood and other swimmers. And there's a sense of community there as well.
Oh, yeah.
So I'm just, I'm returning to my Pisces roots, I guess.
I love that you're Pisces. My mom is too. And I only laughed when you said that, David, because I was very far from like a strong competitor. The Olympics for this past summer, I was not going to be in those.
Yeah, no.
But I did compete,
Yeah, that's all I'm saying. I just said it's good.
My Say is about resiliency. I think you know this, David, that I was supposed to go on vacation, and our plane got canceled twice. Yeah. And you can imagine what it's like traveling with 3 kids in the airport. But, the kids were unfazed, and we still had a really great staycation. Aww. I don't even think they really know what Seattle is, or they don't know the relatives there well. But it really just struck me how much they can bounce back and how much I was taken aback. So maybe it's enlightening.
I'll take it. I am all for bouncing back. It's all good for me. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll get the September edition of First Up.
We'll talk to Associate Editor of Digital Media for the Journal of Pediatrics, Dr. Rachel Moon. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Balinky. Thanks for listening.